Okay. Um, Maybe we'll just get started. Dr. Sunita would join shortly, I think. So I'll present the first case. After that, Sujata would do hers, and then I'll come back. So this is a 20-year-old lady from West Bengal, severe aplastic, very severe aplastic anemia. She received some treatment, and after that defaults, the disease progresses, planned for a HSCT, and she undergoes a transplant in Jan 2025. Those are the conditioning regimens, GVHT prophylaxis. She has a fairly smooth, immediate post-HSCT period, and she gets discharged. So somewhere around 2.5 months later, she presents with breathlessness and noted to have bilateral pleural and some pericardial effusion. Evaluation is not anything suspicious. So that time, there was some worries because she has some cytopenias, whether her graft is doing well, and they, amidst all that, they also considered a GVH and gave her some steroids. She receives POSA plus cotrimoxazole, and she goes back. And those symptoms slowly resolve, and persistent pancytopenia, graft failure, restarted on danazol and eltrombopag, and then she has a microangiopathy, then receives more immunosuppression as a part of that therapy. So this is the background we have in her. Now we come to the current problem which we are discussing. So she presents now with progressive breathlessness on exertion. There is a moderate pericardial pleural effusion, but as you can see from the X-ray, there is a gross pericardial effusion. And it's a hemorrhagic effusion, not many cells, predominantly neutrophils, and I've given you some preliminary information. So what do you think in this lady? From her first transplant, the initial transplant has failed, has come now with a large pericardial effusion. Can one of you comment on what are the likely possibilities for this effusion, and what would you think as the next steps? You could go on.
So we have a haplomatched SCT patient who is 2.5 months later developing pleuropericardial effusions. And so the possibilities initially is, one is serosal GVHT like you said, but the other possibility when we talk about non-infectious, we'll start with non-infectious and then we'll go into infectious. So if you look at non-infectious, which I think a lot of us do neglect, apart from serosal GVHT, the possibility of medication related, whether it's tacrolimus or cyclosporin or one of the meds that they use to prevent GVHT, they're high risk for causing microvascular dysfunction and serositis. And that would also explain why a person would also have concomitant rise in creatinine,
Yes.
concomitant TMA or intravascular hemolysis, etc. And sometimes medication changes can help, but that's of course at the discretion of the BMT doctor. The other possibility is when it comes to, say, infectious causes. Apart from tuberculosis, even CMV can do something similar, where it can cause a pleuropericardial syndrome, but it would be odd for the differential to be 98% PMN, and also for it to cause septations, which would be odd if it's a viral process. That would be more likely and consistent with something that's causing a little bit of exudate for it to cause septations.
Yeah, maybe I think when we think about it, we'll think of it as a primary pericardial problem. There is some pleural effusions, maybe, but that's secondary to what's happening in her heart. So I agree fully. Can someone go into more of the infectious differentials? I think we had a good discussion on the non-infective causes.
Yeah, so as far as infective etiologies are concerned, TB is obviously one of the main etiology which we have to look after with in the setting of this gross pericardial effusion. Apart from that, NT and non-tubercular microbacteria, though they are not a common concern post late engraftment phase, but still in Indian scenario, we have to look after that. And maybe some fungal infections like Aspergillus and all, they can also cause such kind of lung pathology, but causing a pericardial effusion by a fungal would be a bit lower on the cards. I hope the patient was already on CMV prophylaxis, and so that would be
Yes,
not.
yes. So also she is on a mold active prophylaxis, as I had mentioned
Yeah,
before.
so that's what I was
Yes.
about to ask. She must
Yeah.
be on something for fungus.
Yeah, she's
right?
on POSA.
So,
That-
she will be on POSA and she'll be on CMV prophylaxis. So those being in this scenario will be lesser likely, or something breakthrough, maybe more common than those normal fungal infections. So TB I still would think of, because the pleuropericardial effusion alone, although the neutrophilic predominance make it little less likely, that is one thing that you pointed out. But I still would think, because she was being treated as GVH and she has predominantly pleural effusion. Was there anything in the stomach?
A stomach?
Yeah, any
In the,
hepatosplenomegaly?
no. In the
Or
abdomen,
any-
there is nothing.
Abdomen was absolutely fine.
Yes,
So
yes, yes.
hepatosplenomegaly.
There's no lesions in the liver, spleen,
no liver
nothing.
hepatosplenomegaly.
Yeah.
Okay, I still would stick to probably tubercular, followed by fungal infections, which are not covered by your this thing. So she's on POSA prophylaxis already, so it has to be something beyond that doesn't cover, or we may have to look into if the POSA levels are well maintained and something.
Yeah.
If it is not generating adequate levels,
Sure.
so that there is a breakthrough infection, that should be kept in mind. Yeah.
Yes.
Can I make a comment?
Yes.
So this, how old is this patient?
She's 20.
She's 20, young, very young
Yes,
patient. Unfortunately, with the aplastic anemia, the success rate after transplant is excellent. If there is one reason why we should be doing transplants in India, is aplastic anemia and thalassemia, because the success rates are excellent. For this young girl to have graft failure is a surprise. So I would have a chat with the hematologist. Why did you fail? How did you fail this patient? 20-year-old girl, aplastic anemia, why didn't the graft take? Number one. Number two, and the graft failure occurred and now she has been persistently neutropenic for 2 months.
Yes.
So she has a chronic neutropenia, putting her at risk for mycobacterial disease, fungal disease, the entire gamut. And now she's developed a neutrophilic pericarditis, so to speak. So most common thing would be bacterial. I would be concerned about bacterial organisms because the patient has a neutrophilic predominance and she's been neutropenic for a long time. And she's on reasonable posaconazole, ganciclovir prophylaxis. So I would be concerned about bacterial organism. I would go to the lab and ask for the gram stain of the pericardial fluid to see if it reveals, if it gives me any answers before I start doing multiplex PCR in that pericardial fluid.
The other question becomes, did they develop the disease because of graft failure, or did the disease cause an infiltrative process of the bone marrow and the pleuropericardium? That is the primary issue. So what I mean is, if there is graft failure and they have neutropenia from that, yes, it can predispose to a lot of the infections apart from tuberculosis, etc. But the other issue becomes if the immunosuppression led to tuberculosis, which then caused infiltrative bone marrow infiltration and pleuropericardial infiltration.
I think that's a good thought, but we don't have any clear evidence of infiltrative secondary disease in the marrow evaluations that have been done. So that's where we are. Yeah. So I think we have discussed well. So now, so essentially what happened to her is that she worsens, she actually undergoes an emergency procedure, and she has a VATS and a pericardial window, and we didn't find much bacterial or this thing, though we were thinking, and her pericardial fluid grows rhizopus microsporus, and the tissue in histopathology also shows zygomycetes with lot of invasion. Now, I think few things, of course, the thing we want to quickly answer is that how to treat. But before that, can we just think about how did she get it? What are all the things that could have gone wrong in her? And maybe can we talk a bit about the species and also the treatment? So those are the other things we can discuss.
How we get it is the first.
Yes, you
question.
could choose actually whichever you are comfortable and then start talking. Yeah.
She was being neutropenic for long.
Yes, yes.
Like very prolonged neutropenia.
Yes.
And also the infection control practices, as we were discussing in the morning, what are the she could have caught it, and it was also mentioned it was in air. Our spores, high rate of spores, and
Yes.
the infection control practices. Maybe she is not in a proper positive pressure ventilation room throughout the neutropenia, which is not possible in her state. Maybe she's been for months together. She's been neutropenic. So maybe from environment is the most likely cause. We can't pick from where she get, and how could have we prevented? Maybe not really possible. She was it's a big breakthrough. She's on posaconazole. She was on posaconazole, right?
Yeah, she was on POSA, but then you have such a big pericardial effusion, how much you were absorbing, all those things are real concerns for us, isn't it? Yeah, yeah.
Yeah, absorption of drug and interaction is something that always is affected
Yes.
in this population. So we may have to look into whether she's maintaining good levels of drug or not. That is very important. Sometimes we, while treating the patient, when multiple people are involved, sometimes it goes missed that if something is reducing the level of the posaconazole, not only mucositis alone, so some other drug, we have to always keep a check on mucositis, and interaction is what I feel very important. So those two factors I would probably definitely look into. And doing a level in such patients, whether that helps, that is something that we can do to prevent such kind of relapses. And apart from that, we should always think about drugs to bugs which are funguses which are not covered by posaconazole. So
Sure.
that's important.
Yeah.
So that if we keep in mind, then I think we can, our suspicion widens in terms of those species, suspecting those species.
Point that was not brought up was aplastic anemia is a risk factor for fungal disease. And one needs to be careful when we are dealing with aplastic anemia patients. So I'm not surprised this patient with aplastic anemia goes on to develop. That's first point. The second point is posaconazole. How often do our institutions here do posaconazole levels? Do we routinely do POSA level? And POSA comes in a liquid form and a delayed release tablet form. Liquid form is not terribly reliable. Delayed release tablets have better bioavailability. So we switched over from liquid to delayed release as soon as the delayed release came out, and there was some data to support it. So my question would be, was the patient on delayed release tablet?
Yes.
Number one, do you routinely measure levels?
Yeah. So she was on delayed release tablets of posaconazole. I think that's been the standard of care across India now for the last few years. And the target usually one tries to achieve is more than 1,000 POSA levels. But then usually those are done once, and not once they are adequate, we assume things are going well. But she has gone through a very traumatic course, whether the levels have been steady, all those are questions, isn't it? How would you, yeah, please go on.
So the other thing is, how did she get such a bad pericardial effusion to
Yeah,
begin with, right?
yeah.
So a lot of the times, the invasive fungal infections in someone like her would start off from you inhale it, it goes into the lungs. Molds such as, say, Rhizopus mucor, it's notorious for adjacent concomitant pleural effusions. And you have a lot of pleuropericardial ligaments. It likes to track. So another time I saw a case like this is with staph, where it starts with staph aureus.
Yes, yes.
It likes to go to the lung, go to the pleural fluid, and then go along the pleuropericardial ligament into the pericardium. So that's one possibility in terms of how it may have affected the pericardium in someone who's not had sternal surgery, so as to speak.
You know, I like the thought. I also don't believe that she had a primary pericardial mucor.
Yeah.
She did have a small lung consolidation
Yes.
associated, though it's not very prominent. The pericardial disease is sort of the thing that's staring at you. I truly feel that it started in the lung and then moved in. maybe in the coming images I can just highlight that, but thanks for pointing it out. That.
And then you asked about treatment, so I would, while she's on the poster, I would continue it. I would get a level, but I'd also start liposomal ampho-B in the meantime, 5 mg per kg.
Also, sir, how long ago was this, I would like to ask, because there's a recent change in the preparations of posaconazole from the 300 mg have come, which we are actually facing some issues with level. Is there a change in prior preparations of 100 into 3, which we are using to the current 300 mg strand? Maybe in between she's changed because there's availability of 300 mg preparation. Is that something we have to look into?
Yes, that's something important. In India, that's a problem we are facing, isn't it? Yeah. Now, I'll tell you what she received. She received liposomal ampho, and she significantly became better. And the follow-up images shows that things are serially settling down for her. And this is her imaging. You can see that there is some lung involvement, isn't it? It's not that. And she also had a lingular consolidation, probably. That's the way her disease evolved. And the last question, I think we discussed well. I'll hand over to Sujata now for the next one. Yeah.
Thank you. Hello. So this is a case where the test reports are very clear.
Let me interrupt here.
Yes.
Abhi, the first case, I think the important message that needs to be said is that the sooner this patient goes for a second transplant is critical. The question is the timing of the second transplant. The hematologist is going to come and ask us when would be the ideal time to go with the second transplant. She's a 20-year-old girl. I would say sooner the better. I would not wait for 6 weeks, 8 weeks. This is a life-saving measure. Forget the mucormycosis, continue the amphotericin, proceed with the second transplant if they can find another donor.
So you answered the first question in my case. Thank you, sir. So this is a 12-year-old diagnosed AML of intermediate risk who's received induction chemotherapy, defaulted, was restarted on induction therapy around 2 years later, had persistent measurable residual disease which was positive, has received Hydax or high-dose cytarabine, after that isosatidine and venetoclax, and has developed IPA. The posaconazole trough level was 0.15 at the time and was started on isavuconazole. And the serial MRD has remained low positive. So this is a patient who basically has refractory AML, needs a transplant sooner than later, and is planned for a haploidentical allogenic BMT because of the disease status. So that was my question, that when would you give the okay for proceeding with BMT in such a case? And which antifungal would you choose for secondary prophylaxis in this case? So anyone from the panel would like to take this?
She's already have a invasive pulmonary aspergillosis.
Yes, has refractory AML, has invasive pulmonary aspergillosis, posaconazole trough levels were poor, switched to isavuconazole, has achieved a good trough level on isavuconazole.
So basically, we will continue with the same because she was didn't reach with the posaconazole levels were not adequate to this.
Yes, they were not adequate.
So secondary.
Now, we also have to understand that posaconazole levels, when we had done, there was febrile neutropenia, there was mucositis, there were other issues as well. This is a 12-year-old child. So keeping in mind what our pediatric data is for isavuconazole, that's the reason why I'm bringing this up.
No, so she'll again go into febrile neutropenia at least, no? She'll become neutropenic post-transplant. So in such case, if you have chosen a drug which has worked for her previously, and she was not able to maintain drug levels adequately with the other drug, I think we would continue with the same as what I would do in my setting. I'm happy to hear if somebody has different thoughts.
The data are somebody who has aspergillus, how soon can we take them to a transplant? That has been a question for many years. Should I wait 4 weeks after therapy? Should I wait 8 weeks of therapy? The longer we wait, the better. If the patient is in remission, that's excellent. The patient is in remission now, right? From the
No, there is persistent MRD which is positive. So there is some minimal residual disease which is still ongoing despite all the chemotherapy that has been given.
Okay. And the aspergillus treatment has been how many weeks now?
So basically this was at the start of the treatment. 1 week down the line the trough levels were good, patient was stable.
I see.
And the BMT team was now, okay, we have trough levels, patient is stable, when do we go ahead with a
Okay.
transplant?
And this patient with aspergillus has been treated for the infection for 1 week now.
Just 1 week. So
Yeah, it's a little too early to take the patient
Yes,
to transplant.
yes,
In the
absolutely.
past literature, they would say 4 to 8 weeks. Now, more and more physicians are willing to do it after 2 weeks. So 2 weeks of therapy, patient stable, urgency, take the patient to transplant.
Right. Anyone else, or I can move on to the, yeah.
So I think I would also be interested in looking at, like, as Dr. Chandra said, the baseline data. So like, IPA, how was she diagnosed? Was it, say, probable, proven? You get what I'm saying? Yeah.
Proven IPA.
Okay.
I'm not going into that too much because the discussions are
Got
to
it.
come. So it's a proven IPA. We have mycological factor which is positive, a galactine-1 which is positive, or aspergillus PCR which is positive. We have it growing in the culture. We have its susceptibility to isavuconazole. We have all that.
So assuming no emergent need to proceed towards stem cell, I would say a minimum of 4 to 6 weeks. And then you also have to take repeat clinical and say CTing or radiological diagnostics into consideration before you start to consider.
Yes, so you're right. So basically the decision is driven by clinical and radiological stability. So that to see whether there is improvement, no progression, and the ability to continue antifungal therapy during the conditioning or the engraftment period. So that's what, as you all said, that around 6 to 12 weeks is the total treatment. So sometime around the 4 to 6 weeks mark, we do a repeat CT and then decide based on that.
This is why I made the comment. This is all literature.
Yes, yes.
We
this
do
is
not have to wait 6 to 12
exactly,
weeks.
yes, this is
now
what it
we
used
can
to be.
take them to transplant in 2 weeks of therapy.
Yes, so that's what. So it's no longer only based on that, it's based on clinical and stability. What about the role of isavuconazole in secondary prophylaxis? So up till last year, up till the ESIL 10 guidelines, up till then isavuconazole was not recommended as prophylaxis in BMT at all. But now they have mentioned that at least in the adult population, they are saying that you can use it for AML, intensive chemotherapy, during the post-engraftment period and in GVHD as well. Although posaconazole is the grade A recommendation and this is B2. Isavuconazole, yes. In the pediatric population, however, there's still limited data. So they're still talking about posaconazole and echinocandins being used. Now this patient has been taken up for transplant after 4 weeks of treatment, the CT scan showed significant improvement. The patient was stable, was taken up for BMT on 8th of May. There was myeloablative conditioning done because there was MRD was still positive. He was prophylaxed with letermovir, valcyclovir and posaconazole. He developed febrile neutropenia, grade 3 mucositis. The posaconazole was switched to IV. And had pan-susceptible Pseudomonas bacteremia. And he engrafted well, everything was okay, but he continued to have MRD positive at day plus 90. So he he received azacitidine and donor lymphocyte infusion to induce GVL, graft versus leukemic and he developed GVHD of the liver and the skin. This was biopsy proven and was started on steroids. This was all going on OPD basis. On 22nd of August, he developed diarrhea, around 14 to 15 episodes per day. Stool routine showed 1 to 2 pus cells, few RBCs. He was admitted, Jakavi was added to therapy. And on 24th, his stool for C. diff by gene expert was tested positive. So this is a NAT test which has come positive. So what next? Is this gut GVHD? Is this C. diff? So do you start treatment for C. diff based on this NAT report? Do you reduce the steroids or stop the Jakavi? Do you do both? Or do you want any other information?
Is she on antibiotics?
No, was not on antibiotics before. I think Septran, but that's it. That's all.
So, say differential diagnosis in someone who's having a severe diarrhea post stem cell transplant. So, we already know he's developed, this patient has developed
Yes.
GVHD. So, one possibility is gut GVHD. The second possibility is, especially along with the steroids and all that, is CMV of the gut. I know the patient is on letermovir, but you can develop CMV gut disease despite that. The third possibility, which is very obvious, is C. diff itself. Start the treatment for C. diff with fidaxomicin or vancomycin, but also have very low threshold for actually thinking of doing a scope with a biopsy. Check for immunohistochemistry as well, apart from looking at pathology.
How often do you all do a scopy for your patients if you're suspecting C. diff or GVHD?
So I think it's, honestly, it's institution specific. There are some institutes that say, well, you have an answer, why don't you treat that first and we'll see. But a lot of these patients, even when you start C. diff therapy, even though it's the glaring, say, one of the answers, is they don't improve very quickly, a lot of them, in the beginning. Sometimes it takes time. And the question becomes how long do you wait before you realize there's a concomitant diagnosis and it's not just C. diff alone.
True. So this patient was started on oral vancomycin. We don't have fidaxomicin here. The steroids were reduced. The ruxolitinib, as in the Jakavi, was continued. And C. diff toxin assay was sent. It is a send-out test. It's not available in our institute, and that tested negative. This report has come 2 days back. So this, 2 days after the NAT report. So now this is NAT positive, toxin negative. Thoughts? Would you stop therapy based on this?
No.
Well, I'm not sure why you did the PCR first and then did the toxin. In general, the recommendation is you either do the glutamate dehydrogenase enzyme test along with the toxin assay. If both are positive, you don't need to do the PCR. If both are negative, you don't need to do the PCR, patient doesn't have C. diff. If there is a discordance, if one is positive and one is negative, then you automatically reflex it to the PCR. That is the standard two-step test, right, Ramesh? At Ford, I'm sure.
There are some
changes there as well, and so in several other countries now, and even centers in United States, they've gone to a PCR-based test first, but they always followed up with the toxin-based test.
Correct, right.
So the PCR is used because they increase sensitivity to capture the people, but follow it up with the toxin.
Absolutely
test.
right.
So
Thank
that's
you.
it.
Thank you.
Yes.
I think this is an important teaching point for younger trainees. If you're going to adopt that technique of doing the PCR first, please do not start treatment based on the PCR positive. You have to prove it if the toxin is there or not. Because the PCR positivity only tells you there is a toxin-producing gene. It doesn't tell you if there is toxin or not. There is a toxin-producing gene which may be turned on or which may not be turned on. In this case, the gene was not turned on. That's why the toxin is negative, but your PCR is positive. I hope that is clear to the audience. So in this setting, it's very important to wait and see. If the toxin is positive, then of course, and in this case, with 10 to 15 stools a day at this point on steroids, I would be very concerned about steroid refractory GVHD.
Would you would you think anything about the specificity of the toxin assay or the sensitivity of the toxin assay?
The specificity is bad. I'm sorry, the sensitivity is not optimal for the toxin assay. It's anywhere between 50 or 60%. So half the cases you may miss just based on the toxin alone. That is why if the toxin is negative and your GDH is positive, we go on to do the NAT.
So we had not done a colonoscopy yet for this patient. Basically, there was a liver GVHD, a skin GVHD, which was biopsy proven. So the gut GVHD was kind of implied. The C. diff NAT coming positive and a lower sensitivity test coming negative and the stakes being quite high. So we had a big conversation about this, that whether we should stop therapy or not. But let's just go ahead and see. The child spikes a fever of 102. Blood cultures are sent, started on antibiotics now. Blood culture grows pan-susceptible Pseudomonas. So now this is a NAT positive, toxin negative C. diff, but now on antibiotics. Now what do you do? Would you want to repeat the toxin?
How is her loose stool status at this point?
So patient is having fever. Patient is not hypotensive.
No,
the diarrhea persists.
Persists.
So is the diarrhea like blood in stools are there?
No,
Is
no
it
blood.
dysentery?
No
It's
blood.
only-
It's yellowish. It's got food particles. Things are just going in and out.
What is the status of this patient's GVHD otherwise, elsewhere, means the
So
skin
the
and other
liver,
places?
the skin GVHD was, so the liver GVHD was settling slowly. The skin GVHD was sort of going up and down because we stopped the steroids when the NAT came positive. So we just kept the patient on Jakavi at the beginning. So there was some sort of flaring up and down, but that's it.
Why don't we scope her now? I mean, we should scope her now, I think.
Okay,
Ulcers
so
could
what
be
do you
sitting
expect
in-
the scope to tell you? So in terms of C. diff, how would it help you? If you see the...
No, majorly, maybe we're looking for alternative diagnosis other than C. diff. If there are ulcers sitting there, or if there's is only GVHD biopsy, you can maybe find CMV there. This is the
So
This
rule out
patient was
GVHD.
already on letter movie, so
Patient
CMV
is
could
on letter movie.
Yeah.
We've been doing serial CMV viral loads and it was negative. And even there was no cytopenias or anything to suggest that there was specifically CMV colitis at that point. We had done a CT for this patient as well, and that had also not shown anything.
It will still prove a GVHD, no?
Yes.
So
GVHD
means-
definitely. What I'm trying to tell you is there is a patient who's colonized with C. diff. Now you have started antibiotics for a actual reason. Is there a chance that now it could start producing the toxin? Is there any role of
always
repeating the toxin test? If you're keeping the patient off C. diff therapy.
Don't stop. It's a chicken and egg situation. You cannot stop entirely, I believe, here, because you will not be able to prove what you're saying, and there's always a chance that toxin production may happen, what probably I would have done, and still prove GVHD. If steroids are not helping, then we should move on and give her something else so that her diarrhea stops and we get rid of the situation.
Okay, so I'll just go a little quickly. This patient developed, so finally we tried to involve the gastroenterologist to scope her, but he asked for a stool biofire, which came negative. So this is 5 days after the NAT positive for C. diff. So based on this, would you want to discontinue isolation and infection control prevention, or would you still continue it?
I would still continue. She's having loose stools still.
Yes.
She's persisting loose stools, so I think.
Yes, absolutely. So there is no recommendation for repeat testing. Infection control prevention has to continue based on symptom resolution and rather than just test, because a lot of times the NAT can remain positive. Now in this situation, I mean, probably if the LOD had come down and that's why it was not detected on a multiplex PCR, it's possible. So we need to do trough levels. We need to have a multi-step C. diff diagnostic algorithm, and there's no role of repeat testing. Thanks.
What happened with the case? Sorry, do we have a diagnosis?
Okay.
What happened to the patient?
What happened with the patient?
Patient's doing well.
No, do we have a diagnosis for the loose? Fine.
So
Anything other
basically-
than C. diff?
So basically the biopsy has been done before I left for SITSCON. So I think the biopsy will be available when I go back. So I will let you all know.
Do tell us what did you do.
Yes, I will. So I'm just presenting my last case. It's a short case. This is a 3-year-old B-cell ALL patient who has received 4 cycles of induction chemo and had early isolated extramedullary CNS relapse. A bone marrow done after that showed disease remission, MRD negative, and was planned for a haploidentical stem cell transplant. The father was the donor. Both donor and recipient were both CMV IgG positive, and the stem cell transplant was done on 28th of June. This was the prophylaxis which was given. It was cotrimoxazole and twice weekly liposomal ampho-B. On day +1, letermovir was started along with acyclovir. The patient had neutropenia prior to the stem cell transplant itself, and had fever, abdominal distension, and high-grade fever, a lot of mucositis, and on day +5 developed rash all over the body. The skin biopsy was inconclusive. Letermovir was stopped. went on to develop loose motions. Here the colonoscopy was done early. The biopsy showed GVHD. So the patient, and this was quite early, so this was just day +6. Patient was started on IV methylprednisolone and Jakavi. And on day +10, so initially it was thought that maybe this could be a letermovir-induced rash. So the letermovir was stopped and then it was again restarted. And on day +13, the patient engrafted. On day +16, the CT showed a mild symmetrical wall thickening in the rectum and the sigmoid colon. And on day +17, you have a CMV viral load of 1065 international units per ml. And the patient was switched from letermovir to IV ganciclovir 60 milligrams once a day for a weight of 12 kg. So this was 5 mg per kg OD. So do you think that this was the appropriate dose? What would be your threshold for switching from CMV prophylaxis to preemptive therapy? Very quickly, we have only 4 minutes.
With letermovir, low levels of CMV, viremia are acceptable, but there are no threshold per se or any numbers that have been determined where we have to change. Based on the clinical thing, maybe whenever there is viremia, it is not wrong to shift to the treatment part of it.
Yes. So there are no recommendations, even ESIL 10 has not given any recommendations of a specific viral load cutoff. Okay, and letermovir use under 12 years, data is still sort of not yet there for it. So this was not at our center. This is a case which has been shared.
Let me make a point here.
Yes.
This patient has diarrhea or no diarrhea? Had diarrhea?
Had some, but more.
There was GV.
It was yes, it was GVHD.
When the patient is having diarrhea, there is no point in giving letermovir.
Yes.
None of it will get absorbed. So we have to be clinicians first before we start dealing with all these other situations. As a clinician, I would say you're giving every capsule of letermovir is $270 US in the US. It may not be the same price here. Every capsule is $270, and all that it goes out in the stool because the patient has severe diarrhea. And nobody measures letermovir levels. So is it any surprise we see CMV? There is no CMV protection here.
Exactly. So that was basically the point, that we should have switched the patient to IV ganciclovir for CMV prophylaxis a lot earlier.
Let's also make a letermovir IV. It is astronomically expensive.
So even the gut GVHD has developed quite early in this case, even
Yes.
pre-engraftment.
Extremely early. But since it was biopsy proven, we took a second opinion as well.
Yeah, day +6 only.
Yes, it's very early. And the engraftment was on day +13. So we had some, not sure how exactly this came up. The skin rash and the mucositis all came up at the same time. All right, so this patient went on the 19th. So this was 1 week later, the CMV viral load was 440. So from 1,000 to 440, and then on 26th, it's gone up to 4,500. So the ganciclovir dose was increased to 5 mg per kg twice a day. A week after that, it was 19,300. Any thoughts? Is there something we are missing here? We did a CMV IHC on the biopsy as well, tissue, it was negative. This is just serum CMV, which is deanemia, which is increasing. Okay, so I'll just put forward some points and you can just discuss them. So could this be resistant CMV? Could there be inadequate dosing? Should we increase it to 7.5 mg per kg BD? Could there be any sanctuary sites, retinitis or CNS or in the gut itself, although IV should reach there? And the immunosuppression effect as well. So GVHD, giving Jakavi, so that itself will blunt the immunity. Anything?
So in this case, resistant CMV, yes, it is one of the thought process. UL97 has to be looked after in case if it is available. And inadequate dosing, I don't think so, because 5 milligram per kg dose was already going on. Sanctuary sites is, yes, there is a possibility, and moreover in the presence of gut GVHD, which might have paradoxically aggravated or decreased the clearance of CMV, that is another possibility.
So this patient at that center, they decided to give cidofovir, 2 doses of cidofovir, but and fundoscopy didn't show any retinitis or anything of the sort. The Jakavi was tapered, steroids was stopped after 2 doses of cidofovir and 1 dose of IVIG. The CMV viral load had still increased to 1,40,000. So this patient received IV foscarnet after that. And the CMV viral load, I mean the genetic the resistance testing came back negative. Have you all seen anything of this sort, and do we rely on these tests?
So all the levels that you sent were on good immunosuppression, no?
So,
Patient has been on that
yes,
earlier,
on this immunosuppression, and which was decreasing.
which was decreasing eventually, but when
Yes.
the copies...
We can't stop the Jakavi
Yeah,
immediately,
I
so every
agree.
week they kept decreasing it.
And even when you decrease, the effect lingers on for some time. So I believe one reason of this could be that the patient was on immunosuppression, that the viremia continued. Sanctuary site is another thing. I'm sure that you looked into the interactions and everything, right?
Yes.
So I mean,
Yes.
that could not be the reason most of the time when you guys are being careful about it. Only two things I can think of, immunosuppression and probably the sanctuary sites.
Okay.
Which, again, IV should take care of it, but still, those two remain.
Yeah, so this patient basically received Foscarnet for 3 weeks till the CMV was undetectable. Patient settled and now is on Letermovir for secondary prophylaxis and is doing well. So, thank you.
So, how come if it was not a resistant form of CMV, how come the Foscarnet was continued as opposed to switching to GAN?
I think because we had already maxed out on the doses and the CMV was still positive, and the rest we'll chat after the inauguration. Thank you, everyone.